Thank you, thank you. I'll go all the way to 2020 if I have to. Good afternoon. I would like to thank the organizing committee for inviting me to come back to Krakow. I love this city. It's a great place to be. I love the food, I love the people, I love just the ambience outside. It's just outstanding. So, my name is Jorge Castillo. I'm an assistant professor of medicine at Harvard Medical School. I work at the Dana-Farber Cancer Institute. And I do specialize, ultra-specialized on Waldenstrom's. Actually, my practice is over 95% of patients have Waldenstrom's disease. And in my most recent census, we have seen about 1,600 patients with Waldenstrom's in our clinic. So I'm not afraid to say that this is probably the largest clinic in the country, in the United States, for Waldenstrom's. So I want to tell you today about our experience on Waldenstrom's, how do we manage the disease. Now, this is a change of pace. With myeloma, everybody's talking about MRD negativity, trying to get the patients to the deepest response, to have the longest survival. Waldenstrom's is a little bit different. Waldenstrom's is a disease that patients will have for a long time. Probably just 1 in 7 patients with Waldenstrom's will die of Waldenstrom's. The other 85% of people, 6 out of 7, will die with the disease, but not because of the disease. So much more than ever in this disease, quality of life is really important. So we just recently did some analysis in our database, and about the median survival for patients in our clinic is around 16 years. So when a patient comes to see me and they tell me, I read somewhere that my survival is 5 years, and I'm like, more like 15, and they obviously like to hear that. But it's not the quantity, as I've just mentioned previously, it's the quality of the life that we have our patients. Now, here you have my email address. Please feel free to write it out. It will be at the end of the presentation as well. If you have any questions about Waldenstrom's, patients that are challenging, feel free to email me, and I promise to get back to you within 24 hours. All right, so how I treat Waldenstrom's in 2016. These are my disclosures, first of all. 3 seconds. 1, 2, 3. Thank you. All right. We cannot talk about Waldenstrom's without talking about Waldenstrom's. Dr. Jan Waldenstrom's is a Swedish physician. He was a Swedish physician. He died. But he described this disease in 1944. This is not the only disease he described, actually. He described a number of diseases, immunodeficiencies, autoimmune conditions. This physician was extremely productive. One day he was being praised. And they told him, doctor, we're amazed of how important your contributions have been to medicine. And he said, well, I'm just a doctor. I'm just a clinician. I just report what I see. I just describe what I see. So he was not only a fantastic clinician, but he was very humble too. And we need to learn about that too. And obviously, always describe what we see. Waldenstrom's macroglobulinemia is sometimes considered a plasma cell dyscrasia. Sometimes it's considered a lymphoplasmacytic lymphoma. The WHO classification includes it as a lymphoma. And it's a lymphoplasmacytic lymphoma. The interesting part about this lymphoma is when we talk about other lymphomas, follicular lymphomas and things like that, we talk about monoclonal lymphocytes. And when we talk about myeloma, we talk about monoclonal plasma cells. In lymphoplasmacytic lymphoma, we have monoclonal lymphocytes that are related with monoclonal plasma cells, and those are related with monoclonal lymphoplasmacytic cells. So it's a disease made out of 3 separate clones of cells, and all of them are related to each other. How do we know that? Because recently, we described a mutation called the MYD88 mutation. I'll talk about that in a minute. And when we run the MYD88 mutation in the different compartments, lymphocytes, lymphoplasmacytic cells, and plasma cells, all the cells have the mutation. So we know it's a disease made of 3 separate clones. And that's what makes it so much more interesting. Now, we can see the cells. The bone marrow is the organ that is typically affected by this disease. I would say in over 95% of patients. We do have some patients with lymph node-only disease, for example, or what we call a Waldenstromoma, which is just a very localized area of disease, but those are the minority of cases. So we can see here, a very homogeneous lymph node, some evidence of plasma cells and lymphoplasmacytic cells and mature lymphocytes, and they will all make the disease. Now, the typical feature of this disease is not only how it looks, how the bone marrow looks, but also the ability of those cells to produce IgM. IgM is a fantastic molecule. It's one of the largest molecules that we have in our body, and that's why it's called macroglobulinemia, because it's a macroglobulin. It's a macroprotein, and that's how Dr. Waldenstrom described it. He didn't know it was IgM. He just knew it was a large molecule, and that's how he left it. IgM was described later. So in this specific graph, there's one very important teaching point. On the x-axis, I have put here the percentage of bone marrow involvement, from 0% to 100%. More bone marrow disease when you do a bone marrow biopsy. And on the y-axis, I have the IgM levels, from 0 milligrams per deciliter all the way up to 14,000. And each dot is a patient. I just want to show you that when we look at a population of people, really there's no relation between the bone marrow involvement and the IgM level. Just as a sample, we can have a patient with almost 90% disease and 12,000 IgM. That makes sense. And we have patients with very little disease, 5% with a very low IgM. That makes sense. But we also have patients with almost 100% disease with very little IgM. And we have patients with very little amount of disease in the bone marrow with very high IgMs. So the first thing I tell my patients is don't go out there and compare your IgMs, because really what one IgM means to one patient is not the same for the next patient. Now, if we follow the IgM in the same patient, then that's a good tool, because we can see how the disease progresses and obviously how the disease responds to treatment. But you cannot assume or compare bone marrow involvement and IgM levels between patients. Now, to complicate things further, laboratories also vary. We have, in our experience, up to 20% plus minus IgM levels from laboratory to laboratory. So a patient had 1,000 in one laboratory, comes to see us, and it's 1,200 or 1,300 IgM, and they believe and think that they are progressing. And I don't think that's the case. It's just our laboratory is 1,300, and your laboratory is 1,000. So you need to be very careful about mixing and matching IgMs from different laboratories and try to use the same laboratory all the time to get a more reliable trend. Now, Waldenströms can present in different ways. And clinically speaking, it's very heterogeneous, very heterogeneous. And up to last year, we had only 2 criteria to diagnose Waldenströms. One of them was the lymphoplasmacytic lymphoma in the bone marrow, and the other one was the presence of this IgM monoclonal spike in a protein electrophoresis. And that's enough. That's enough to make the diagnosis. Now, clinically speaking, patients can present with many different manifestations, as if there were many different diseases. Just to give you an example, about 20% of our patients present with neuropathy. These patients typically have a low IgM. Usually the IgM is below 1,000. And they are not anemic, they don't have any hyperviscosity. So this IgM is very different than the IgM of patients who have hyperviscosity, for example. Patients come to see me, IgM is 8,000, they are bleeding through their nose, they're having blurry vision because they're having hemorrhages in the retina, and they're not anemic. And their bone marrows might be even 5 or 10%, and they have an IgM that is extremely high. Those are patients who are hypersecretors. So this syndrome is very different than this syndrome in terms of the presentation. We do have patients who come to see us and they're anemic, and that's the most common presentation. And the most typical picture is we do a bone marrow biopsy, and the bone marrow biopsy is typically packed with disease, 80, 90% disease. That means the good bone marrow doesn't have enough space to produce good red cells. Having said that, some patients will have only 20 to 30% disease, and the anemia is driven by hepcidin. A portion of our patients will actually, the malignant cells will produce hepcidin, and it will cause an iron deficiency anemia, either absolute or functional. And that is another way how patients with Waldenström's can have anemia, not precisely because of bone marrow replacement. In some cases, it could be secondary to hemolysis as well. So as you can see, when I took the job and they told me you're going to see about 1,000 patients with Waldenstrom's, I said, it's all the same disease. I'm going to get bored because I like to see the myelomas and lymphomas and all the varieties. But now I see a patient and it's not boring because I have my hyperviscosity patients, I have my neuropathy patients, I have my cryo patients, my cold agglutinin patients, and my iron deficiency patients, and my extramedullary patients. So they have different syndromes. Still, all of them are called Waldenstrom's. But they, clinically speaking, they could be very, very different and very challenging too. This is just to show you how the back of the eye of a patient with hyperviscosity looks like. Here on the left, we have obviously hyperemia. It's congested, it's engorged, the veins are engorged. And we can see this little sausaging, like little sausage. That's actually one indication to treat. Even if the patient feels well, this could be one indication to treat because what's going to happen next is this, little retinal hemorrhages all over the place that sometimes can put the vision of the patient in danger. So these are the patients who need to be plasmapheresed immediately and need to be treated immediately as well. Because once we plasmapherese them, within 3 to 4 weeks, the IgM is going to go all the way back up because we're not doing anything to the lymphoplasmacytic cells producing the IgM. We're just filtering the IgM out. So those are, for example, reasons why we need to treat patients relatively quickly. This is a patient with cryoglobulinemia. This is another reason sometimes why we pherese patients. As you can see, an old lady, and she presented with this livedo reticularis in the hands, dorsum and front, very heavy, discoloration, violaceous discoloration of the lower extremities, as well as the earlobes. Once plasmapheresis has been done, and in these patients, we tend to warm up the solution. And even sometimes we have to warm up the room where the patients are being pheresed because they're so sensitive to the change in temperature. And you can see how circulation has been reestablished. All these microthrombi had gone away, and the patients feel better. And obviously, treatment should follow because plasmapheresis will not control them for a long time. Neuropathy is another way in which patients with Waldenstrom's can present. And there are different ways in which the nerves can be damaged by the disease. The typical way, and I would say over 60% of the patients, will have what we call demyelinating disease. And, an EMG study will show you that. If a patient comes with neuropathy, I tell them, well, we need to make sure that your neuropathy is because of the Waldenstrom's. The fact that you have Waldenstrom's and neuropathy doesn't mean that neuropathy is because of the Waldenstrom's. And the worst thing you can do for a patient is to give them chemotherapy for a neuropathy that is a diabetic neuropathy. So you need to work these patients up and make sure that you have at least a reasonable suspicion that the neuropathy is driven by the IgM. So in this case, a demyelinating process through an EMG study or a nerve conduction study is something that we tend to do. We tend not to biopsy these patients. We try to do as much as we can without biopsying the nerves of these patients. Because once you take the nerve out, and you need about an inch of a nerve to make a clear diagnosis of whatever is happening in there. Once you do that, that area is basically dead. There's going to be no movement. There's going to be a muscle atrophy, and it can even be painful. And it's going to hurt forever. So if you don't want to do that, it's better if you try to do the workup the least invasive possible to try to figure all this out. So if I find a patient with demyelinating disease, I tend to get these antibodies, and if obviously these antibodies are positive, the likelihood that the neuropathy is driven by the IgM is very high. Now, we can have patients who have axonal disease, and the EMG can also give you this pattern, but this is less likely to be related to Waldenstrom's, more likely associated with amyloidosis, more likely associated with all these other processes, cobalamin deficiency, HIV disease, Lyme disease, whatever have you, depending on the epidemiology where you live. And more recently, we're seeing now these small fiber neuropathies, which are very rare, burning and electrical shocks in the hands and the feet of those patients. When you do an EMG or nerve conduction studies that are normal, because are the small fibers that are affected, not the large fibers. So all these are things that we need to understand so we can actually treat our patients appropriately. My recommendation is somebody has neuropathy, they need to see a neurologist. They need to have the nerve conduction studies so we understand what is the underlying process, so we don't treat patients so they will not get better. So there are many reasons why we need to treat patients. What I want to tell you, too, is that over 50% of the patients that come to my clinic do not need to be treated. They come to see me. They are essentially asymptomatic. They have a good quality of life. They have no other problems. And those patients can be watched expectantly for years. I mean, I have a patient who has been expectant for the last 30 years. And there are patients like that who will not need to be treated for a number of years. But if the patient at some point develops, a low hemoglobin, low platelets, symptomatic hyperviscosity, severe neuropathy, extramedullary disease, lymph nodes, hepatosplenomegaly, pleural effusions, renal involvement, CNS disease, which is very rare but happens. So all those are reasons to treat patients with Waldenstrom's. Cryoglobulins, cold agglutinin that are symptomatic, amyloidosis that is symptomatic, systemic. Those are reasons why we need to treat these patients. And what do we do? How do we treat them? And what I'm gonna list here from now on is actually based on the little evidence that there is in Waldenstrom's. I mean, in myeloma, we just saw thousands of patients, hundreds of patients, clinical trials. That doesn't exist in Waldenstrom's. It's such a rare disease that most of the trials are phase 2s with maybe double digit patients. Maybe there are 3 or 4 randomized studies ever published. So the strength of the evidence is not so great. So the first treatment that we tend to use in our clinic is the combination of bendamustine and rituximab. And this is based on a subset analysis from a randomized control study. The randomized control study from the German group actually compared bendamustine rituximab versus R-CHOP. And they basically separated in different groups: follicular, marginal zone lymphoma, and small lymphocytic lymphoma, and lymphoplasmacytic lymphoma. And these are the results on the lymphoplasmacytic lymphoma. But you can see here, 22 patients in one arm, 19 in the other. That's the best we can do. So we have noticed that bendamustine rituximab works really well for patients who have extramedullary disease, like a lymphomatous disease. Lymph nodes, liver, spleen enlargement, kidney involvement, pleural effusions. Bendamustine rituximab works really well on those patients. The overall response rate is over 80% with a complete response rate of 20%. And the progression-free survival is over 5 years. So in this graph, I mean, you don't need to be a statistician to know that in this Kaplan-Meier, benda-rituximab does much better than R-CHOP. This is progression-free survival. Now, nothing is without a potential price to pay. Potential stem cell toxicity, although the Germans swear that there's no, we think that it might. Cytopenias, infusion reactions to rituximab, and this very tiny risk of a secondary malignancy, usually a leukemia, that we need to be aware of and our patients need to know about before we move forward with treatments. So since this is a randomized control study, I put it first, a little bit stronger evidence. Now, cyclophosphamide is another alkylating agent that we use. And, since bendamustine rituximab is better than R-CHOP, this is less favored in our clinic because it's cyclophosphamide, rituximab, and dexamethasone. That's about it. So, but there are a number of studies. We have a German study, the Greek study, and has been recently updated. So those are prospective studies using, dozens of patients. So it's widely available. So I think it's a good option, here. Very well tolerated, and the response rates are really good too. If you can see, the overall response rate is very similar to bendamustine rituximab. The complete response probably is half. But do we really need complete response? Well, nobody knows that. I don't know that. And the median progression-free survival is about 3 years when it's given up front too. So we can see here, but based on age, obviously younger patients will tend to do better than older patients, but that's true for pretty much everything else that we're going to be talking about today. So side effects, obviously patients will lose their hair. That doesn't happen with bendamustine. Cytopenias, and again, about a 1% risk of secondary leukemias on those patients too. But this is a very good option for frontline treatment. Something that we're using more in our clinic because we did the study, so we are not biased at all, as you can see. This is a phase 2 study that we run, but there are 2 additional studies that are supporting the use of bortezomib in combination with rituximab. One from our own colleague, Dr. Gabriel, and one from the Greek group. We combined bortezomib with dexamethasone and rituximab. We had a fantastic response rate, a fantastic complete response rate as well. And the beauty of this regimen is there's no risk of secondary malignancies compared to the chemotherapeutic agents. And you can see this is basically the kinetics of IgM dropping. This is the median IgM at baseline after cycle 1, cycle 2, cycle 3, cycle 4. So after induction, patients are nicely depleted. Within 4 to 8 weeks, the IgM is dropping. So it really works really well, and it works really fast. And during maintenance, patients continue, dropping their IgMs. So we have very nice responses. The problem, obviously, is neuropathy, as we all know. But we have been switching towards subcutaneous weekly formulations, kind of modifying a little bit what we did for the paper in JCO 2009. And our patients continue having less of a quick response, but the depth of the response has been maintained. It takes longer, but the depth is very similar. Obviously, thrombocytopenia, and what some patients do not like is the fact that they need to take steroids all the time and need to be taking zoster prophylaxis all the time. But this is something that is necessary in this type of regimen. Carfilzomib is not available here, and there's only one study, ours, that we published a couple of years ago in combination with rituximab and dexamethasone. Very similar response rate, non-neuropathy, which is a good thing. But on the other hand, we have other problems with carfilzomib. Hypertension, we have low IgG levels, we have increased glucose, increased cholesterol, there's an increased risk of cardiac complications. So again, there's no free lunch. There's always a risk that we need to balance with all our treatments. And something that we're using less and less is nucleoside analogs. And I think this is much more available here, fludarabine, for example, with rituximab. This is something that in a recent randomized study, single-agent fludarabine showed to be better than single-agent chlorambucil, but I'm not surprised about that. We have about 3 randomized studies in CLL that are already showing that. So I'm not surprised about this finding, but that doesn't really bring the regimen towards an increased preference in my mind. A good response rate, good duration of the response, but this is the main issue that I have with fludarabine. It's just the risk of AML in myelodysplasia is about 5 to 10%. So that's actually 10 times higher than any of the other chemotherapy agents that we have. And obviously, if the patient might be a candidate for transplant, then we would like to avoid a stem cell toxic as it is. What we're doing in our practice is we're giving it to older patients at lower doses, shorter courses to try to minimize toxicity. One caveat here is on patients who have CNS involvement by Waldenstrom's. It's called Bing-Neal syndrome. Fludarabine gets very nice into the CNS, much better than bendamustine. Bendamustine does it very, very little, pretty much nothing else. And it's actually less toxic than methotrexate, that high-dose methotrexate. So fludarabine Rituxan has become our standard for patients who have CNS involvement until ibrutinib came around. But going into reality, this is a study that we just published recently. This is a complicated graph, but I'm going to make it very simple for you. Everything black is rituximab single agent. So this is what we're doing in the community. This is what is happening in the United States when you are older than 65 and you go and see anybody in the community. 50 to 60% of patients are getting rituximab alone with nothing else. Without fludarabine, without bendamustine, without Velcade, just Rituxan alone. And is that a good thing? Is that a bad thing? We don't know. We're still trying to analyze and see if the addition of chemotherapy maybe improve survival or improve responses in patients compared to getting rituximab alone. We don't have a good understanding of what this is, and we are trying to figure all this out. This is a large national database. This is not our clinic's database, as you can understand. But rituximab single agent is very well tolerated. Is widely used, obviously the most commonly used regimen in the United States. The issue that I have with rituximab is specifically in Waldenstrom's, and the problem is you have to see a lot of Waldenstrom's to notice this. The responses are delayed, sometimes 3-6 months until you can actually see the response to Rituxan. The infusion reactions, everybody reacts. Actually, the Waldenstrom patients tend to react worse than the regular lymphoma patients. We have a paper that we just published called Rituximab Intolerance. About 10% of our patients get to a point in which they cannot get rituximab anymore. The more they get it, the worse the reactions are. About 10% of our patients. And obviously the flare that patients can observe, about 30% of our patients, when they get Rituxan, the IgM actually goes higher. And if your IgM is already 5,000, I don't think that's a good idea to increase the risk of having a hyperviscosity on those patients too. So there are a number of reasons why, in my mind, rituximab alone might not be the best option for everybody. But I guess it's going to be a good option for somebody, right? And I think that's what we're trying to figure it out. The role of maintenance has been debated. There's only one study, our study. And this is not a randomized study. This is just retrospective data. So it's very weak data. It's our study, but I mean, I need to tell you what is right. This is very, very weak data, just retrospective data showing progression-free survival benefit, overall survival benefit. But again, there's no randomization. There was no balancing using any type of propensity scoring or anything like that. This was done before I joined the group. I would have never done a study like this. So, and so based on this data and the data, favoring maintenance in follicular and marginal zone lymphoma, then we tend to recommend maintenance rituximab in those patients. But if you go to the Mayo Clinic, they will tell you no maintenance, for example. So there are some people who are in favor of maintenance or not. Now, the German group is doing bendamustine rituxan and then randomizing, rituximab versus observation. So we're still waiting the results of that randomized study, and that's the one that I think will show benefit, if any, in a more conservative manner. So this is what we have been doing until 2014, 2015. But things have changed in the last few years. And this is what I wanted to, what I mentioned earlier. We identified, Dr. Trion's laboratory identified a mutation on this gene, the MYD88 gene. The MYD88 gene is a toll-like receptor. It's one of the receptors that gets activated first in the infectious process. And, in infections, the IgM goes higher first, and then the IgG comes back later. So MYD88 has to do with activation of the toll-like receptor, has to do with generation of IgM very early on in the immune response. So in these patients who have this mutation in nucleotide 265, the MYD88 is always activated. So IgM is always being produced. So that's as simple as that. Now, when they identified this mutation using whole genome sequencing, they found that about 90% of patients with Waldenstrom's actually had the mutation. So they went and they looked at patients with MGUS. They looked at patients with IgM myeloma. They looked at patients with IgM secreting CLL, IgM secreting marginal zone lymphomas. And they noticed that in most of those populations, the prevalence of this mutation was actually less than 10%. So it's not only sensitive, but very specific for patients with Waldenstrom's macroglobulinemia. Obviously, when the data was presented, everybody was like, well, we need validation. This is validation. These are 20 different studies from different parts of the country and the United States, Asia, Japan, India. So different places all showing the presence of the MYD88 mutation using different techniques. We did initially whole genome sequencing, then we developed a PCR testing for it. And different places basically confirm that around 90% of patients with Waldenstrom's carry this MYD88 mutation. Now, the WHO this year has described the MYD88 mutation as part of the diagnostic criteria for Waldenstrom's. So from now on, we will use the bone marrow involvement, the IgM, monoclonal protein, and the presence of the MYD88 mutation. Now, there's a 10% of patients who will not have this mutation, but they will still have the other two criteria. So those patients remain as Waldenstrom's. Actually, WHO wanted to rename those patients as a different condition. But when we looked at those patients, the bone marrow level of disease, the pattern of involvement, the IgM levels, everything was exactly the same as the regular MYD88 mutant patients. So we cannot call those patients not Waldenstrom's because they have the monoclonal paraprotein, but they don't have the MYD88 mutation. So good friend Wang Yang at our laboratory is actually working on trying to understand how this mutation works. And he has basically done a lot of headway. One of the first findings was that BTK was involved in the signaling of MYD88. MYD88, it's a very narcissistic molecule. It likes to look at itself all the time and bite with itself all the time. So for MYD88 to signal, it needs to bind to another MYD88. And in anybody in this room, assuming that nobody here has Waldenstrom's, then when you get infected, that's when that happens. But when you have the mutation, the L265P mutation, the binding of MYD88 is happening all the time and activating all the time. It activates through BTK, activates through IRAK1 and 4, activates through PI3 kinase inhibitor, a number of different other inhibitors, but finally getting to nuclear factor kappa B, and obviously with all the effects that does have, which we already know. And there are many more now. We just described another marker called HCK that is also one of the targets of ibrutinib. So our understanding of the pathway, and now it looks more like a network, it keeps growing. Additional whole genome sequencing studies led by Dr. Hunter, part of our laboratory too, identify these mutations in this gene, CXCR4. It's actually the only malignancy, so far I know, in which there are mutations in that gene. There are congenital mutations in that gene in a disease called WHIM mutation, warts, hypogammaglobulinemia, infection, and myelocathexis. But this is an acquired mutation. This is not congenital. This is acquired. And the difference with the MYD88 is the MYD88 is always present in the same spot, 265. Here we have, so far, 40 different mutations that we have identified. And they're not all in the same place. And some patients have even more than one mutation in the CXCR4, which makes it very, very difficult to identify. So Sanger sequencing is probably the best way to identify these mutations, but not everybody has the ability to do this. And we are actually, there's 2 studies that have validated this already, but obviously more validation is necessary to try to identify it. So about a third of the patients with Waldenstrom's will have a mutation in this gene. Why is that important? It looks for survival, really there's not much more importance. MYD88, with or without CXCR4, they behave the same. But if you have no MYD88 mutation without CXCR4 mutation, your survival is really poor. So those are the patients who really do poorly. And in our clinic, we have seen that. Patients who are resistant to bendamustine, patients who are resistant to bortezomib, patients who are resistant to carfilzomib, resistant to rituximab. Those are the patients who have no mutations. Doesn't make too much sense. You can imagine that patients with a mutation will do worse. But in this specific scenario, patients with no mutations do worse. And those are very, very, we are trying to do whole genome sequencing on those patients to see if there's any type of mutation that we can target. So it took us to this. It said MYD88 signals through BTK. Is there a BTK inhibitor out there? Name is ibrutinib. And we generated this phase 2 study that then we extended. And this was led by Dr. Trion. My name is someplace around here. So 63 patients, median age of 63 years, typical Waldenstrom's, anemics, high IgM, high degree of involvement of the bone marrow, with adenopathy and splenomegaly as well. This is a simple graph. Each line is a patient's IgM level. And you can see how the IgM levels just drop after beginning treatment. You know, within one cycle, within 4 weeks, we actually see dropping of IgMs at least 25% within 4 weeks. And this is the hemoglobin. Each line is one patient's hemoglobin. As you can see how within 4 weeks, the hemoglobins start increasing as well for each patient. These are the progression-free survival, the overall survival. Obviously, at 18 months, we're going to be presenting a more updated data for ASH. And when we look at the groups to try to see which group benefited and which group didn't benefit from ibrutinib, you know, regardless of the age, performance status, the IPSS, beta-2 microglobulin, hemoglobin level, IgM level, we notice really that genomics is what drives the response to ibrutinib. That's where CXCR4 comes into place. If you have the MYD88 mutation, but do not have the CXCR4 mutation, your response is 90%. If you have the MYD88 mutation and also have the CXCR4, so a double mutant, then the response is actually lower. And you have no mutations whatsoever, the responses are even lower. So the mutations really are important when you want to treat your patients with ibrutinib. We don't know if these mutations affect how other treatments work. And we're trying to study that right now with other patients who are getting proteasome inhibitors, rituximab, and things like that. But for ibrutinib, we have really strong data to suggest that patients respond differently based on their genomic profile. So based on this, the FDA approved ibrutinib for Waldenstrom's. last year. The European Medicines Agency already approved it too. The UK didn't endorse it, and I think Canada has not endorsed it either. But some other countries are endorsing it and covering it. So based on that, in our practice, the frontline approach, I don't think we're ready for ibrutinib yet because really there's no study done in frontline, even though we think it's going to work. We are working on it. We are actually 20 out of 30 patients enrolled at this time for the frontline study, and it's been very good. I mean, the purpose of the study is actually do whole genome sequencing every year on those patients to try to understand how the mutations affect the disease, and the disease affects the mutations and the ibrutinib. But, we're doing bendamustine rituximab and Velcade dexamethasone rituxan and cyclophosphamide dextrituxan. And for the relapse patients, ibrutinib has really become our first choice. The only caveat is we genotype everybody. So if you have the MYD88 mutation, you get ibrutinib. If you don't have it, you don't get ibrutinib. Because the response rate, if you don't have the MYD88 mutation to ibrutinib, is less than 10%. So I don't want to spend $100,000 per year on an indefinite treatment for a response rate of less than 10%. Now, the caveats with ibrutinib, nothing is perfect. I just told you, and my lectures are always balanced. So I'm going to simplify this graph for you. We have a light green and a dark green bar. The dark green bar is the bone marrow involvement at the beginning of the study, and the light green bar is the bone marrow involvement at the end of the study, right? So each 2 bars is a patient. And you would expect that with such a dramatic IgM dropping, the bone marrow should also have decreased dramatically, because that's what we're used to see with Velcade, with bendamustine, with cyclophosphamide. But in this case, we can see here, no change. No change, no change, no change, minimal change, minimal change. So we're actually seeing that the patients are having better hemoglobins and lower IgMs, but their bone marrow involvement hasn't changed. How is that possible? So what happens is IgM drops because of a transcriptional mechanism. We are blocking the production of IgM, but we are not killing the cell. The cell is being frozen in the microenvironment. Is being isolated in the microenvironment. So they are dormant, but they are not dead. So whenever we stop ibrutinib, within a week, the IgM starts climbing back up. Even in patients who got into VGPR, nobody got into CR. Even in patients who got into VGPR for 2 years, whenever you stop ibrutinib for a week, the IgM starts climbing back up. So this is a treatment that is indefinite. These patients should take 3 pills per day for the rest of their lives. Other problems, anemia, neutropenia, thrombocytopenia, all these are early side effects. The more delayed side effects are the things that I'm more concerned about. Increased risk of bleeding with procedures, atrial fibrillation, about 10% of the patients, hypertension, about 5% of the patients can have problems like that. And that could be a problem, because if you have a medication that causes bleeding, and then you have atrial fibrillation, and you have to be in a blood thinner on top of that, then that really complicates some patients' lives. So if there are other options, then immediately we switch them to other treatments. But if that's the only option they have, then those patients sometimes tend to have to deal with the atrial fibrillation and the ibrutinib and the care associated with those 2 treatments. So as I mentioned before, the mutations have to do a lot in how you respond to ibrutinib. If you have only 1 mutation, the response is 90%. You have 2 mutations, it's around 60%. If you have no mutations, here it says 29%. But 2 of these patients actually had a MYD88 mutation that was not identified in the first pass. So this is actually 5, and from those 5 patients, this is actually less than 10%. And this is an update that we published later on in New England Journal. So there are novel agents, novel pathways that we need to really use to try to understand and treat Waldenstrom's a little bit better. So ibrutinib is the first step. We did a study on idelalisib, and it was really disappointing because we were expecting something similar to ibrutinib. Started giving the patient, within 4 weeks, the IgM should be dropping. We didn't see that. We saw a lot of liver toxicity, grade 3 or higher ALT increase. So out of 5 patients, 1 died quickly because of progression of disease. 3 had severe ALT elevation that we had to stop treatment on. Only 1 patient tolerated well. So after 5 patients like that, and with the stopping of the idelalisib studies frontline, because of increased risk of infectious deaths, because of CMV reactivation and pneumocystis carinii pneumonia, we decided to stop that study. So we accrue only 5 patients out of 30, and we call it a day, and we are publishing that paper shortly. We are running a study now on venetoclax, BCL2 inhibitor. We are up to 6 patients out of 30, responding very well. We had a patient with no mutations, resistant to bendamustine, resistant to Velcade, is responding to ABT-199. So this might be the answer for those non-mutant patients. And there are other ways. Now, Dr. Trion's laboratory is working on this, which I think is the highly exciting mark of the day. As I told you, MYD88 likes to bind to each other, right? It binds to itself to actually signal. So we are trying to devise molecules that will prevent that binding from happening. But that could be a problem, because we need MYD88 to bind to each other for the immune response. So we want to try to make it as selective as possible to work only on the mutant cells, but not on the non-mutant cells. If this gets into clinical trials, and I think it will in the next year or two, I think it will be highly, highly interesting. This is just a little bit of idelalisib data in a prior study that showed some response. In our study, it was not as successful. This is ABT-199, 100% response rate. We're doing a formal study. So I want to summarize the lecture today by saying that MYD88 is an important development in Waldenström's. Over 90% of patients have the mutation. CXCR4 mutations are very important too. I think it should affect how we treat our patients. Specifically, we want to try ibrutinib in those patients. The BTK inhibitor ibrutinib is safe, effective. Our new generation BTK inhibitors now, with no bleeding, no AFib apparently. The medication is called acalabrutinib. But there are many other ways of looking at those. Daratumumab is next. There's an anti-CXCR4 antibody that is next in clinical trials. So we have a very busy portfolio for Waldenström's down the road. But we cannot do this alone. So we need our patients. We need referrals. We need collaborations with other institutions to try to make these clinical trials as cost-effective and time-efficient as possible. Thank you for your time.